good evening, everybody, and thank you for giving me the opportunity to speak to you today. I do love to spread the word about peripheral cold injury. A quick disclaimer of my own, which is that I'm here as an independent, and although I work for the MOD, I'm not representing the MOD today. A quick introduction to myself so that you got a little bit of context. I've worked for the military for over 25 years. The first 20 years was working as a GP for the army. Then for the last 5 years, I've moved over to occupational medicine. My main area of extended practice has been in remote medicine, often in quite austere environments, and I've been lucky enough to spend a fair bit of time working across the world. And over the last 10 years, I've established a cold injury service for military personnel, and I lead on that for Defence, UK Defence, and as well as on a couple of NATO committees. So what I'm hoping, oh, my slides aren't changing. Hang on a minute. Oh, there we are. So what I'm hoping to do today is to give you a quick overview of non-freezing cold injury and freezing cold injury, or frostbite, and a little bit of how to manage them in the field and in primary care. I expect for many of you, I'm going to just be confirming what you already know, but for others a little bit less familiar with this area of work, I hope it's going to make you feel confident when dealing with patients presenting with peripheral cold injury. So we'll look at non-freezing cold injury first of all, and I'm just going to give you a little bit of background to NFCI and Defence, because this really is still the principal group in whom we see peripheral cold injury. I'm sure you're all aware of how prevalent NFCI or trench foot, the two are really synonymous, was during World Wars I and II. And indeed, cold injury has really altered the course of wars across the centuries. Interestingly, it wasn't such an issue during the Afghan war. And looking back at that, we think it may be due to a couple of main factors. First of all, it was a very high tempo offensive campaign. And really, the risk of peripheral cold injury is principally in being static in the cold rather than exercising in the cold. And the second main factor was that personnel were returning to FOBs, or forward operating bases, in most evenings, which meant that they could change clothes, get dry clothes, rewarm and so forth. They weren't having days on end in sort of damp, cold conditions. But the current geopolitical situation, and especially the Russia-Ukraine conflict, is bringing peripheral cold injury back into sharp focus. And what this means for UK defence, and indeed much of NATO, is that we've got many more troops going to exercise in countries close to Ukraine and Russia. So we've commonly got troops in Poland, Estonia, Finland, Norway, Sweden. And obviously, with the more people exposed to cold and extreme cold, we're naturally sustaining more cold injuries. And the training is, of course, focused on the possibility that NATO Article 5 may be invoked. And Article 5 is the cornerstone of NATO, and which states that an attack on one member of NATO is an attack on all of its members. And so, of course, we're perpetually close to being drawn into combat in particularly cold environments. So what causes NFCI? Well, simply put, it's really caused by people being cold environment conditions that lead to them cooling to such a degree that peripheral tissues may be damaged. And of course, because of the volume to surface area ratio, that tends to be hands and feet. I'm not going to go into the physics of cooling. You all know the basic facts is we all gradually cool in cold environments. The colder the ambient temperature, the quicker we cool. It's worse with wind, it's worse if we're wet, and you can compensate up to a point by shelter, good footwear, decent clothing, and so forth. Of the internal factors in NFCI, the most pertinent of the body's physiological response is the body's physiological response to cold. It's controlled by both central and peripheral thermal receptors, but really just think about the hypothalamus as being the king of central thermal control, your sort of main thermostat in the body. The peripheral receptors do exert an effect, but it's much less predominant. It's still important in controlling rates of blood flow to different regions of the body, though. And it's the blood flow to the skin, particularly in the hands and feet, that regulates the skin temperature and hence heat exchange with the environment. So if we're overheating, then we have a lot of peripheral blood flow so that you can try and lose heat from the body. And obviously in cold environments, you're shutting down peripherally. So in a cold environment, the skin blood flow is absolutely paramount. As I said before, it tends the cohort predominantly affected is the military across the world, but there's also many different trades at risk. And if you look in harbour environments, or you look at power line and telecoms workers, or those working in construction, fishermen and so forth. And I'm based up in North Yorkshire, and I'm pretty confident that a large numbers of farmers have non-freezing cold injury, but they just regard it as part and parcel of the way that they live. It is becoming an increasingly common recreational problem because of the increased interest in outdoor activities. As they've gone up, so have the number of cold injuries. And you'll have seen in the journal, in journals, there's cases noted in cyclists, in mountaineers, wild swimmers, and so forth. So having looked at what causes NFCI, what actually is NFCI? And it's quite surprising, really, that we don't know an awful lot more than Ungley, who wrote the initial papers during the Second World War. We don't know a lot more today than he described then, and he described it as a vasoneuropathy, and really that just obviously means vaso meaning vessel and neuro nerve, and pathy damaged. And we don't know an awful lot more beyond recognizing that, if I'm absolutely honest, but we've started to piece a few things together. So if we separate out the vasopathy first of all, so it is a poorly understood injury, but it's thought to arise from a combined insult of direct cold damage, from hypoxia, and also from a reperfusion injury, possibly mediated via free radicals. There's quite a lot of research that implicates the endothelium being damaged in these cold conditions. And it's thought that it may be that endothelial damage that contributes to the subsequent development of cold sensitivity in some people who sustain an NFCI. So if we look at the neuropathy, and that's the nerve damage that occurs in NFCI, it's been studied since the sort of mid-40s, but principally in animal studies. And often what they've been looking at is large fibers, often large fibers in rats, rather than the small fibers that tend to be infected in NFCI. What we do know, though, is that the degree that there is a spectrum of damage that ranges from a simple edema that will settle on its own through to the myelin sheath damage, and then to structural nerve damage, the actual sort of necrosis. And where you sit on that spectrum is a figment of how cold that peripheral tissue has got and how long it remains at that low temperature. So we do see this this sort of spectrum of injury. And more recent investigations done in humans has really, there's mounting evidence that what we're seeing is a small fiber neuropathy. So what contributes to NFCI and what heightens the risk? There's lots of different categorizations of risk factors. I quite like this one, which is was devised by a chap called John Castellani, who works at the US Military Research Center, Environmental Research Center. And he divided it into these 5 risk groups. I'm not going to speak about the environmental ones because you're all familiar with those. So we'll just talk a little bit about the other risk factors. So first of all, if we're looking at the mechanical, this is really one of the most important risk factors. And as I alluded to before, we're not especially worried about people exercising in the cold. So many of you, I'm sure, will have gone out and done runs on cold days, or, you know, been cross-country skiing or downhill skiing in extremely cold conditions. And while you're moving, you're okay. It's when you stop. And so one of the things that we're trying to push in terms of education for troops is that the danger is remaining static in the cold. And in fact, if you look at the research papers in the military, it is generally speaking, so when people have been stationary, that they are sustaining injuries. So there's a lot of research that came out of the Korean War, and that was often prisoners of war. Or people in sentry positions. The Israeli army have done a lot of research, and most of their cold injuries are incurred when they're holding static positions on the northern border with Lebanon. So that really matters, the active passive bit. Clothing and footwear, you know about. Posture is interesting as well, because while you're sitting, you get quite a lot of pooling of blood into the lower limb, and that's a rewarming that produces rewarming. As soon as you stand up, in order to maintain your blood pressure, you get this peripheral vasoconstriction that shifts a lot of blood out of the peripheral tissues, and so you generally get colder. So if you are wanting to sort of preserve the temperature in your feet, you're much better sitting down than you are standing up. The physiological risk factors, if we look at race, we know that Africans are at heightened risk of cold injury. And the reason for this is the CIVD, or hunting response, which some of you will be familiar with. For those who are not familiar, what this is that when we go out into the cold, the initial reaction of the body is to shut down the peripheral vessels in order to preserve core temperature, because what we want to maintain is core body and major organs warmth. So we shut down the peripheral tissues, peripheral blood vessels. The peripheral tissues start to cool. At a certain temperature, the body thinks, hang on a minute, my peripheral tissues are now at risk, so I'm going to open up my blood vessels and try and rewarm. And you'll recall times when you see really flushed, bright red hands, and that's the CIVD response, and it's trying to rewarm the peripheral tissues. And you get this sort of you get this cycle of vasoconstriction and vasodilation. Now, some really nice work done by Matt Maley down at Portsmouth has shown that in Africans, that CIVD response kicks in at a lower skin temperature and is less brisk. And because of that, they get overall, in the same conditions, they will get a bigger dose of cold compared to their Caucasian counterparts. And similarly, women seem to be well, they definitely do. They cool more quickly, and their CIVD response is less effective. So again, they get a bigger dose of cold. But these are quite small degrees of heightened risk. And if you think about the normal distribution curve, where, you know, for height, for example, you've got short people, average people, and tall people, you will, within each of those races, have people who are particularly good responders to the cold, particularly poor responders. And so you may have a good you know, someone who's black but is a very good responder to the cold actually faring better than a Caucasian person who just has a very poor response to cold. So they're sort of small, they're small measures. In terms of psychology, certainly in the military, ethos and leadership plays a great part in numbers of cold injuries. So if people are encouraged to report early, and that it's not a failing to be becoming cold, then often it can be nipped in the bud and they can be rewarmed before they sustain an injury. Whereas if it's, you know, you're just a wuss if you're not managing to keep warm, then there tend to be higher rates. The other thing is about experience and about people experience. So both experience in terms of being practiced in the field, but also being in a situation where fear is engendered. In both of those, you tend to get well, first, certainly with a fear, you get a fight, flight, fright response, an adrenaline rush, and peripheral vasoconstriction. In terms of experience and practice in the field, I'm sure many of you will have had days on the hill where you get to the end of the day and you really cannot be bothered to look after yourself. And unless you are practiced and just go into your routines of rewarming, drinking, heating food, and so forth, you will be at heightened risk. And people who aren't used to doing that tend to have higher rates. And then finally, there's some medical clauses. So Raynaud's, you'll know, obviously in Raynaud's, you've got a vasospasm that's triggered on exposure to cold. That's a very dense shutting down, much more than you get in the usual physiological response to cold. And because they've got this quick shutting down, they are going to cool more quickly than other people. Acrocyanosis is a similar condition to Raynaud's. I won't go into it. And there are other conditions and medicines like beta blockers that will impair people's ability to withstand cold environments. So that's really the risk factors. So I'm just going to go on now to the mechanism of injury. And this is always really important in trauma, isn't it? You know, we're always taught what was the mechanism of injury? You know, was this a high-speed RTA or was this a very low-speed one? To have in our minds what sort of injuries we're expecting. And the same is exactly true of cold injury. And what we do know is that you have to have been cold to the point of complete numbness, i.e., you've lost sensation for at least an hour. And that's probably a fairly conservative measure. I think it's more likely to be that you've been cold to the point of complete numbness for at least an hour. And yeah, I think I'll just go on to the next slide actually to explain this a little bit more. So what you see when you have got that, we're talking about hands here. So if you're looking at the skin temperatures, and there does tend to be quite a lot of confusion between talking about ambient temperatures and skin temperatures. So just be very clear that what we're looking at here is tissue temperatures. So when tissue temperatures drop below about 28 degrees centigrade, we start to lose the strength and power. You know, when you just cannot do quite what you want to do as effectively in the cold when your hands are sort of dropping. At less than 24, you get a reduced joint mobility, and that, you know, the synovial fluid is getting a little bit more viscid and so forth. Below 20, you get a reduced nerve conduction velocity, so you're just not as good as doing things in the cold. And at less than 15 degrees centigrade, you get that loss of manual dexterity. So you start to become clumsy trying to do buttons up or trying to do your shoelaces up and so forth. And then at less than 8 degrees centigrade, you get this loss of tactile sensation. We know from human studies that you only are at risk of cold injury when your skin temperature drops below 5 degrees centigrade. So we're quite careful when we're assessing patients to understand the conditions and their sort of the whole picture of when they sustained this injury. Because if I've got a soldier saying to me, yeah, I could reach round, undo my clips on my webbing, I could take out a magazine, I could reload, I had no problems with that, I can immediately say, you haven't got a cold injury. Whereas if they're saying, I was standing on a sentry duty and my hands were so cold, I ended up cradling my weapon, and I was like that for about 2 hours before someone took over from me, I'm immediately thinking, okay, well, that's enough mechanism for there to have been a cold injury. So just take that into account when you're talking to people. But also just a little bit of a warning is that because someone has lost sensation in their hands and feet doesn't mean per se that a cold injury has happened. It simply means that their tissue temperature has entered a zone where it might occur. So if you have a look at this was a study of only a small number. I can't remember exactly how many, but it was a small number. But what we can see is, look, the lowest skin temperature recorded was 1.9 degrees centigrade. So way, way into that zone of potential injury. Someone had a toe temperature of less than 5 for almost 3 hours. None of that group had any symptoms or signs of cold injury afterwards. So all we're saying is that in that at that skin tissue temperature, someone is at risk of injury. So how do we diagnose it? Well, the diagnostic criteria are that there has to have been this mechanism of injury, sufficient dose of cold. They have to have lost feeling for at least 60 minutes, but probably a lot longer. They have to have experienced a rewarming pain for longer than 30 minutes. So all of us have had that intense, really unpleasant after snowballs, playing snowballs, pain in your hands that is excruciating. But we all also know that that passes quite quickly. And so it extending to 30 minutes or longer really is unusual. So we're looking for that. And we're also looking for neurological symptoms, principally a diminished sensation or an altered sensation or a heightened sensation that lasts for longer than 24 hours after that exposure to cold. And we're also taking into account the function that I described on the previous slide. So that's the diagnostic bit. What we do try to do is prevent people getting the injury, because once you've got the injury, there's not a lot we can do about it. We just have to wait for it to recover. So what I try to do is in the MOD we rely very heavily on hand and foot inspections by the chain of command to try and keep the troops safe. They're non-medics, and so I thought back to the Lake Louise questionnaire, which a lot of you will be familiar with, which is the questionnaire for lame people who are trying to identify those at risk from altitude sickness. And the same principles really apply here. What we're trying to do is differentiate who we can keep safely in the field and who needs to be evacuated to medical care. So what we did was took 100 patients who were ultimately diagnosed with cold and NFCI in the cold injury clinic, and we looked at each of the symptoms they had and the likelihood ratios that resulted in an ultimate diagnosis of NFCI. And we built them into this NFCI field assessment tool, or the NFAT. So if people have got extremely cold hands and feet, the commanders use this, and it's a traffic light system of basically of whether they should rewarm, recheck, or they can continue, or they need to go to the medic. So what do we do if we think someone has got an NFCI? Well, the first thing to do is to warm people up and recheck them in the field. If we took every soldier out of the field that developed coldness with numb hands, we wouldn't have anyone left in the field. So the important thing is to warm people up first of all. And just remember that really the only thing that effectively warms people up is either exercise that uses those big muscles, like your quads and hamstrings and so forth, or some kind of external heating system, which some of you in mountain rescue may use, and other people can improvise. So you could put warm water into bottles and put them on front of chest, back and chest and so forth. You know how to do that. Anything else like hot drinks, hot food, extra layers, they're comforting and they reduce the rate of cooling, but they don't warm people up. So just always bear that in mind. So we get people warmed up and we recheck them. If we think that the person is likely to have got an NFCI, then they must move to a warm environment as soon as possible. And it depends on your situation what that warm environment is. So it could be a heated tent, it could be a heated building. If you're really stuck, it could be, in a sleeping bag with someone else, or ideally it can be to a medical centre. The really important thing is that if you've got a single case, then something has to change. If you're either going to rewarm them and put that individual back in the field, or if you're taking them out and you still have other individuals, you've got to mitigate that risk in some way. I'm not going to go into that today, but you just need to think about it. So what do we do? So you need to examine the person, but only examine them once they're fully rewarmed, because if you're thinking back to that slide with the thermometer on it, you know that even in someone who hasn't got an injury, if they're cold, their nerves don't transmit signals properly. So you need them to be fully rewarmed before you do the neurological examination. I just do pinprick, light touch, and vibration. I do the vibration really to exclude a large fiber problem, and I do the pinprick and light touch because pinprick seems to be the most the sensitivity that is most frequently lost in NFCI. And this examination is really, we're looking for a small fiber sensory neuropathy. That's what the purpose of the examination is. And just a little bit about what the differential diagnosis may be. So if it's in terms of cold related conditions, we do often see a sort of normal exaggerated or exaggerated response to cold. So sort of for the first few hours, it starts to look like they may have an NFCI, but the following morning they are completely back to normal, and that we would just regard as an exaggerated response to cold. We're always on the alert for Raynaud's phenomenon, because as you can imagine, Raynaud's typically first presents 18 to 25, something like that. And that's exactly the age group that we tend to be looking at. And there has to be a first episode, and that is likely to be when they're on exercise. So we get a lot of first presentations of Raynaud's. And then I think there are people who definitely are just more sensitive to cold than other people. And often you can tease those out just by saying to them, before this incident, what were you like with the cold? When you played football, did you wear pitch gloves? Or when you were the one, playing outside, were you always the one who needed to go in before others, and just things like that. In terms of non-cold related conditions, we see a lot of neuropraxia. So we have, if troops are out for, a week wearing the same boots, they may have slightly damp socks that produce a lot of friction. And we see this transient neuropraxia just from wear and tear. We call it exercise hand, exercise foot. We see it a lot when they do a trench digging exercise, where they have a lot of abrasion from gloves just against the skin. Then there's also carpal and tarsal tunnel, and then there's other causes of peripheral neuropathy, which there are a host of reasons, and there's also idiopathic. We check for B12 deficiency, folate deficiency, diabetes, and interestingly, you can get a peripheral neuropathy in pre-diabetes, which I hadn't realized before I did this clinic, thyroid and infectious diseases. And we have seen several cases of HTLV1, which is uncommon in UK, but because we have quite a big immigrant population in the military, we've seen several cases. That's it. For those of you who don't know, it's a similar virus to HIV. So what do we do? Well, the problem is that once you've got NFCI, we're really just waiting for it to go away. In the initial stages, most people don't need any pain relief. Some people are, if they have got pain, it can be treated with paracetamol or brufen. I don't actually find those very effective at all, but medics who can't prescribe anything more than that will often try with that. If we've got someone with a really good going pain, we tend to use amitriptyline. It's not terribly well evidenced because we only use it for 2 to 4 weeks, and of course, any neuropathic effect would take 4 to 6 weeks to come in anyway. So I suspect it's simply that we're giving them a good night's sleep, and so they feel better. What is really important is to titrate down as quickly as you can. We generally give 2 weeks, and they have to come back and ask for more, and we really try and wean them off at that stage. The other thing we do is you try not to overprotect. So a bit like with back pain, with back pain, the tendency is for people to want to do nothing, and that's not helpful. And similarly with cold injury, we want them to carry on doing stuff outdoors, but we want to keep them within an hour of being able to rewarm, simply so that they don't get a further bout of cold injury. We give them advice on clothing, and we give them advice on footwear. What we tend to see is that there are three groups really of patients in terms of their recovery time. We have some who recover within days to weeks, and we think that those are probably reflecting a perineural edema. Um, and then we have those that take sort of months and up to a year, and we think that is probably myelin sheath damage. And then we've got those who take a year or more, and sometimes several years, and that's structural nerve damage where they have got to regrow the nerves. And we know that in some there is structural nerve damage because we have a designated clinic where they go. It's a tertiary care clinic where they go, and one of the tests they have done is a skin biopsy where they put a pan-neuronal dye on, and they can count the nerve fibers. So we know that there is structural damage in some patients. And that's it on NFCI. And then I'm moving on to FCI. So I don't know if you want to ask questions on NFCI at this point while you remember them, if you've got any. Otherwise, if there aren't any, we can just go on to Frostbite.
There's one question that's come in about NFCI. So I think it's worth asking now
Yeah.
whilst it's fresh in everyone's mind. So George, I'm sorry for pulling you out here, but George has asked, from your experience, is cooling down the core temperature quickly, like a diving into freezing cold water, have a better outcome than slow progression of NFCI from the limb to the heart? And they are talking in terms of resuscitation and or full recovery of tissues and brain activity.
So that seems to be a mixture of central cooling and hypothermia, which I'm not going to cover today, and peripheral cold. Um, what I would say is that just think back to the dose of cold. So it's how cold the tissue gets and how long it stays cold. So I suppose if you're doing a dive and you get profoundly cold, but you're back up within 30 minutes, that's not going to sit within the time frame where we're worried about a peripheral cold injury. Um, I have to say, in my experience, we tend to see it in people who've been out for several days in damp, cold conditions where it's increasingly difficult to get clothes and boots dry, and they've just been out for a long time. We don't tend to see it in people who cool very quickly, but also have the ability to rewarm quite quickly. I don't know if that answers
Lovely.
the question.
I'm sure it answers enough. And another one's just come in as well from Suzanne Thomas. Suzanne, hello. For those of you that don't know, I'm just going to give a little shout out to Suzanne here. She is one of our wonderful, wonderful, amazing, incredible. I couldn't do what she's doing fundraisers for trauma care. She has just recently completed the Brighton Marathon with a very good time, a time that I'm sure a lot of people would be envious of. She's about to run the London Marathon, and ran the half. It's the Welsh Marathon as well, Suzanne, I believe. And then he's running something else soon as well. Like an unbelievable effort going on here for All for Trauma Care. So, Suzanne, just whilst we're live on a webinar, I do want to give a huge shout out to you and a thank you for everything that you do. However, a question has come in from Suzanne as well, which is, are BMI and age risk factors?
Okay, so I'm going to do the age one first because that's a bit more straightforward. So age does come into it, but not until about the age of 50. So for the cohort that I look after, it's irrelevant. But from the age of 50, basically our thermostatic mechanisms just start to become less efficient. So yes, it does after that age. Um, the BMI is we don't really know. So on one side, people with high BMIs have got better insulation, and so they do tend to cool more slowly. but they also tend to exercise less and are able to exercise for only short periods, and so they don't have the benefit of the rewarming. Conversely, if you've got a skinny malink, they cool often more quickly. Not always, but they may cool more quickly, but they have the ability to use exercise to effectively rewarm, and they can sustain that for the amount of time that you need to exercise. So just as a little aside for people, if you've got numb feet, you need to be doing really, good aerobic exercise for 15 to 20 minutes to fully rewarm your feet. And I don't know about you, but I'm pretty hopeless. If I'm feeling that cold, I jump around for a few minutes and then I stop, and I'm not very good at it. But you really have got to keep at it. And it's an important thing to know, because if you are in a survival situation, then you've got to just, know that you've got to keep going.
Wonderful, thank you. And finally, just before we move on to the next section, anonymous attendee has asked, do hormonal changes affect it?
Yes. So in women, yes. So we know that women taking the contraception containing estrogen have a less good CIVD response than those who are not on contraception. And they are more protected when you come to the menopause. So there is some effect, but again, it's one of the minor pieces of the jigsaw. It's not a big effect. Yeah, and that's about it, really.
Wonderful. Thank you, Sarah. And now we can carry on with your second half of the presentation.
Okay, so freezing cold injury or frostbite is what we're looking at now. And you'll be pleased to know it's another spectrum of injury. So the first thing is when do people get frostbite? What are the conditions in which it takes place? So the first thing to know is that our tissues freeze at about minus, oh, well, not at about, at minus 0.55 degrees centigrade. So it follows that for us to get frostbite, we either need to be in sub-zero ambient temperatures or touching something that's sub-zero. And again, we see the spectrum of injury dependent on how cold tissues have become and for how long. Generally, what we see is a gradual and progressive cooling, and eventually freezing happens. Interestingly, it's during the subsequent thaw and reperfusion that most damage take place. And just try and hold that in your mind, the fact that this is principally a reperfusion injury, because you'll see when I do some photographs later how that plays out in patients. So let's have a look at a little bit more detail what happens during this reperfusion phase. So the initial physiological response is that the blood vessels constrict, you get this vasospasticity, you get inflammation, and you get swelling, and that leads to increased stickiness of the blood. And so instead of the usual smooth flow of blood in vessels, it starts to sludge and stagnate. And that, along with other mechanisms, leads to coagulation. You get blood clots. The blood clots block vessels. That causes shunting between arteries and vessels, as blood has to sort of find a way round that blockage. But in finding the way round the blockage, of course, you leave whole segments of tissues with diminished delivery of oxygen, and you get an ischemia eventually. So there's quite a lot of different grading systems that have been used. I like this Cauchy one because it's easy to remember. So I'm just going to tell you a little bit about Cauchy, because I think he was quite an amazing doctor. He's French. He was born in Normandy, which is paradoxically flat as a pancake. He fell in love with the mountains when he went skiing in the Alps with his family, and he ended up as a A&E doctor in Chamonix. He himself was involved in over 1,000 mountain rescues, principally from the Mont Blanc Massif. because every year about 30,000 people, I think, still attempt to scale Mont Blanc, and his hospital was sitting in the shadow, so it had a lot of cases of frostbite, and he was struck by the devastating injury that frostbite is, and he set out to improve care. And he developed this grading system, and he also set up a department of medicine at the hospital. And he really set us onto a different path in terms of management of patients. Really sadly, on Easter Monday, so not almost coming to the anniversary, in 2018, he was guiding some skiers in the Aiguille Rouge Massif, and that he was involved in an avalanche and sustained a fatal head injury. But he left behind this some really good work and this grading system. And if you have a look, the grade 1, no cyanosis. So this is where you may get the sort of clear field blisters, and you get no loss of digits in grade 1. In grade 2, you get the cyanosis, the bluish or the blood filled blisters just on the distal phalanx, just the fingertips, and that's a grade 2. If that extends up to the metacarpal phalangeal joint, then that's a grade 3, and beyond that, so extending more proximally, that's a grade 4. And grade 4 is 100% risk of amputation, grade 3 high risk. So again, just try and hang on to those fingers a little bit in your head. So you've got an understanding of what's happening physiologically. So let's just have a look at what it looks like. So this, you can see, is grade 1. So they've got these areas of skin affected, but none of them, it's not looking bluish. None of them are blood filled. And all of those will recover really nicely. They'll take a while for the skin to settle. It'll take a while for the sensation to go back to normal, but in general, they will recover really well. And what I found fascinating is that I had expected that next to any frostbite, you would get an area of transitional sort of tissue where one would expect NFCI, but in fact we're not seeing that, and those with grade 1 and 2 seem to recover very well. So this is grade 2, and this is at different stages. So if you look at top left, well, both top ones actually, those are quite fresh pictures, but further down you've got some that are much more advanced, and the significance of the cyanosis or the hemorrhagic blisters is that the freezing has gone deep enough to hit the vascular plexus. So that's what you're sort of, that's what's leading to it. So that's grade 2. So this is grade 3. You can see it's the same sort of colours, but it's just extending further up the hands and feet. So that's the grade 3. These pictures are from colleagues, so I'm very grateful to them for having given me them. And then grade 4, so this is where this is a very, very severe injury that's extending well into the foot and beyond, or into the hand and beyond. And in terms of what it looks like to start with, I think, so just bear in mind that this is an injury that happens with the thaw and reperfusion. So this is someone just after they've been thawed. And if you didn't know better, you would imagine that this was wasn't looking too bad. This is day 2, and so you can see already, now that this is a really serious injury. But we have had cases where people are lulled into a false sense of security in terms of how it looks to start with. This is day 3. And this is day 28, where they're starting to mummify and lose digits. And then these are photos from Professor Chris Imray, who I'm sure many of you know. This is a South Korean climber who fell into a crevasse above Everest Base Camp and was rescued after 24 hours. So she'd had considerable cold exposure. This is her hands immediately after defrosting. Well, actually, that might be the same picture. And then this is at several months on. So you can see again that what didn't look like too bad an injury is in fact a very severe injury. But if you use the Cauchy grading scale, you'd know that right from the beginning, this is a serious injury that you've got to get to definitive treatment. So this I'm just going to whip through really, but it's just to show you that post-Cauchy, because we've had a good grading system, it provided a baseline to assess new treatments. And so the thrombolytics like alteplase, they were used at Hennepin, which is a centre that sees a lot of frostbite cases in the US. And they found that for each hour of delay, so each hour before these people are treated, there's an additional 27% tissue loss, which is huge, isn't it? You know, huge when you're thinking about people's fingers. What has really come to the fore in the last couple of decades is iloprost. Iloprost is a stable synthetic analog of prostaglandin, and it mimics its properties. So it works by inhibiting platelet aggregation and producing some vasodilation, and it's also got some fibrinolytic properties. And that has become a really revolutionary treatment for frostbite. It's much easier to use than the thrombolytics with fewer side effects. So I just wanted to show you this. This is a relatively small study done by a doctor called Alex Poole in Yukon. And he is right up in the northwest of Canada, where there's this race called the Yukon Quest. And if you look at the top left, you can see it's dog sleds, but the dog sledders, they're all appropriately equipped, you know, and they actually don't really have any bother with the cold. But there has been a fashion for people to race behind the dog sledders using the paths they've created, but they like to wear mesh trainers and lycra, and quite a lot of them develop frostbite every year. So Alex has a nice pool of people for his research. But if you have a look at this, if you look at particularly, so grade 2, we wouldn't expect that much digit loss anyway. But if you look at grade 3, where there's a high risk of amputation, 100% salvage rate, and grade 4, where in the Cauchy scale, you would expect 100% digit loss, there was 50%. And that is really very important if you're thinking about people retaining maybe a thumb and a digit in terms of their function and the way they can live in future years. And this is just this is actually, I think, of a thrombolytic, but it's just to show you pre and post treatment what the vascular perfusion looks like. So in terms of what you would do if you had someone in the field with a frostbite, so do remember that FCI care or frostbite care always comes after your ABC or March assessment, whichever system you're using, and also always prioritize hypothermia over peripheral cold injury. For the purposes of today, I'm assuming that we're talking about an isolated FCI with no other injuries. So management's always determined by what is feasible and practical in the local conditions. You know, you have to be adept at implementing management principles and adapt them to what you have available to you at the time. Only thaw the affected area if it's very unlikely they're going to refreeze. If you remember that this is a reperfusion injury, you do not want them to reperfuse more than once. So if you cannot get them out without refreezing, then don't thaw them. Handle it very gently, remove any jewelry, you know all that because of the swelling and so forth. Frostbite is incredibly painful, and most people who've got a good ongoing frostbite during rewarming will need something at opiate type level. Try and rehydrate them as well as rewarming. That helps with it helps reduce vascular stasis. And then you've got to rewarm the affected parts, and you're rewarming until they're sort of warm and pliable to touch. You then need to just dry them, pad them dry, just very gently pad them dry, don't sort of rub them. Some people like to use aloe, elevate if you can, and then transfer to definitive care. Try not to allow people to walk on damaged feet, and think twice about whether you're going to remove their boots if they have got to walk out, because you'll never get them back on again. But those are sort of for more remote and difficult environments. Just in terms of what you do for rewarming, the water needs to be 37 to 39. I mean, it's just sort of a nice warm temperature for your hand. If you've got a mild antiseptic, put it in. If you haven't, don't worry. If you're using a bowl, you've got to keep stirring otherwise you get this this area of cold water around the feet or hands. What the Americans have taught us to use is this sous vide, which you can just buy on Amazon for about 20 quid. And you put that in the water, set the temperature, and it keeps the water at a nice temperature, which is a lot easier than having to repeatedly keep putting warm water in, avoiding scalding the person while you're doing it. But you get the picture, and you can work out, what you've got and what you can do. So the key points really are that all frostbite looks the same when it's frozen, and thawing tissue promptly and getting people to iloprost or to thrombolysis saves digits. And that's the sort of key message, is time equals tissue. In practice, it can be quite difficult to manage in austere or dangerous situations. And the first thing is, are you going to get that person out, or are you going to stay put? And then if you're overseas, should definitive care take place in the host nation, or should you be getting them home? We've tried to address that with a flow chart for our doctors and medics. You don't need to remember any of this, but we've just put it into a flow chart that's really looking at the grades of FCI, grades of frostbite, whether there is thrombolysis or iloprost available in the host nation or not, and what to do accordingly. What you'll see is that we've built in there as well that if you can, discuss with an FCI specialist while you're deciding what to do. So in summary, for those of you who may be covering expeditions or traveling overseas, you really need to make your plan before you set out, because you need to understand what is available in each country you're traveling to. So for example, iloprost only arrived in the US last summer, and it's not widely available still. It's not available, for example, in Estonia, but it is used absolutely standard in Norway. So you need to understand where it's available. You need to recognize frostbite early in the field, do the best care you can. If you can triage using telemedicine to somebody who really knows what they're talking about, then do that. And if you think it's a grade 2 to 4, two doesn't absolutely, it doesn't, the prognosis is not much better with iloprost or thrombolysis. The difficulty is that to start with, it's quite hard to determine whether it's a 2 or a 3. And so we would say, on a precautionary basis, if it's 2 to 4, consider iloprost or thrombolysis. And you're ideally you want to use host nation medical treatment facilities, because you can get them to it so much more quickly, and time equals tissue. But if you cannot get those treatments, then you want an urgent CASEVAC home. And I just finally want to talk about the International FCI Care Group, or International Frostbite Care Group. So what I realized when I was trying to provide guidance for soldiers working in different parts of the world is that I didn't really know what was available where. And so we've come together as a group. So John Castellani, he's US military research. Jen Dow, I think she's chair of Wilderness Medical Society. Many of you will know. Josie Ann works up in Yukon. She's a pharmacist. Chris Imray, I'm sure many of you will know. He's like UK Mr. Frostbite. Rachel Nygaard works out of Hennepin and sees a lot, and has done a Hennepin grading scale as well. Alex Poole, I mentioned, he's up in Yukon. Titus is US military. He works up in the Alaskan National Guard. Afton Seeley, she's a research physiologist again at USARIUM. And Arik Victor works in Colorado and sees a lot of frostbite. So we sort of have set up a group where we're trying to, well, here's the aims. So the aim is that we want people to be able to access standardized evidence-based care. We want people to be able to access experienced advisors. We want to develop national, which feed into international databases, and that will form the basis for multi-center trials. Where we also want, we want to be able to signpost to anybody. So, anybody be able to go onto a website and say, okay, I'm in India, I've got frostbite, where should I go? We want anybody to be able to access these experienced advisors. We've also developed a generic frostbite patient transfer form, because the knowing what people have had and what treatment has happened so far is really quite important once they come home. We've got interested parties so far beyond that sort of core group in all these countries, so we're very pleased that it's building. These are people who have said we're centres that deliver frostbite care, so we're just starting to work with them. We were really lucky in that when we sort of gathered together as a group, Canada on their own had already had a very similar idea, and so they managed to secure some funding to develop a frostbite website. So if you look up their website, the www.frostbitecare.ca, you'll see that they've got the material from our resource group on there. Chris Imre and I are establishing a sort of UK arm of that group. And the website is not quite launched, but it's going to be launched soon, and that'll be ukfrostbite.com. So really, we're just introducing that to as many people as we can. And that's it.
Wonderful. Excellent stuff. Absolutely excellent stuff, and fascinating, as I told you it would be. So I did promise you it was going to be fascinating, and I've been enraptured. So let me just get this up and then go away. I've got a little thing at the top of my screen that's not letting me share. There we go. And hopefully everyone can see everything correctly now. They can. Wonderful. So throughout that entire thing, we have had questions come in. We've had 5 questions come in so far, and I'm sure there's going to be more. However, just for let me just get the chat up because I've got a little link. Fantastic. So this is your chance, the big red thing that's on your screen that's not an A. If you are not a member of Trauma Care and you want to get a CPD certificate for tonight's fantastic talk, now is your chance. Just scan the QR code that's on your screen and it will take you through to a type form. Don't worry, you don't have to sign up to anything. You don't have to do anything like that. It goes purely to us. We keep the information, we keep the data. Well, I do, because I'm the inside data protection officer. All you have to do is, if you are not, repeat, not a member of Trauma Care and you want a CPD certificate for tonight's talk, scan the QR code that's on your screen now or follow the link that I've just popped into the chat, and you can fill out the form and get your CPD certificate. However, for members of Trauma Care, you will get your certificate tomorrow at some point. I'm not promising any times because that would be really silly of me. So we have had questions come in, Sarah, so I hope you're ready for these. So the first question, I'm sure you'll be fantastic. You've been fantastic all night. So the first question is coming from George, who has asked, will fluid resuscitation help with frost injuries in any way? Or is this contradicted in any way? As far as they're aware, there is no active treatment in the pre-hospital environment other than passive warming and Beazle.
So I think any rehydration is going to marginally improve their condition, just because it improves the vascular flow. So I'm not aware of any contraindication to using fluids. What was the second bit of the question, Anna?
So using fluids, is this contradicted in any way?
No.
And as far as they're aware, there is no active treatment in the pre-hospital environment other than passive warming and diesel.
So you can use I can't remember if I've put it on a slide. It is worth trying some aspirin or ibuprofen, just because of the effect on blood flow. And to be honest, there's not a lot to choose between them. So either of those would be helpful to use at the point of injury.
Wonderful. Thank you very much. Um, I think a lot of these questions are kind of going to go on the same path tonight and maybe branch off into different answers. So we'll go through them all just in case you've got something
Mm.
else to add on. So Harriet's asked, when rewarming as a frontline para, they've always been taught to rewarm slowly. For frostbite, do you have guidelines on time taken to rewarm?
Okay, so I think for frostbite, there isn't, you don't want to particularly rewarm slowly. You just want them to rewarm. The thing that will limit you probably is pain. So you've got to stick to that sort of 37 to 39 degrees centigrade. And it's just however long it takes for it to become pliable. So I wouldn't worry about slowing it down. Interestingly, in NFCI, it's always been said that you must rewarm slowly. But if you dig into the literature, we've never been able to find any reason for that. So again, I suspect it's simply because it's quite painful.
Fantastic. Thank you very much. And Josh, hello, Josh, has asked, thanks very much for an interesting talk, which a lot of people have also commented in the chat. I hope you can see that as well, just how amazing it was. Given there is a thrombotic element to blood stasis as described, if prolonged extrication to a hospital is try that again because it's a bit wordy. Given there is a thrombotic element due to blood stasis as described, if prolonged extrication to a hospital, is there any utility to a dose of aspirin in the pre-hospital phase whilst thawing? They noticed that it was part of treatment prior to thrombolytics. Thrombolytics? Told you. Is there an evidence base for it or purely theoretical? And I can repeat that if you want to.
No, that's fine. So that's the one we covered before. Yes, there definitely is worth giving a stat dose of aspirin or ibuprofen immediately. Yeah.
Okay, and to follow on to that, they're asking, Josh has asked, is it 300 milligrams aspirin dose or more analgesic like 600 to 900?
300 milligrams.
There you go, Josh. And finally, well, I say finally, something might pop in whilst I'm asking this. So the final question that's in right now, what are the pros and cons of O2 admin?
Oh, of oxygen. Well, so that's, I think, referring to the belief that hyperbaric oxygen therapy can help in frostbite injury. The problem is that there's never been any controlled studies. So, what you would really need to have to know if hyperbaric oxygen helped would be to have three people with similar frostbites, one who had hyperbaric oxygen, one who had normobaric oxygen, one who didn't have oxygen, and we haven't got that. So some people do advocate it, but if I was a patient, I would be looking for somewhere that did thrombolysis or iloprost treatment. I wouldn't be looking for the hyperbaric oxygen.
Perfect. Thank you very much. And concise and wonderful answers all the way through there. And I hope everyone, and in fact, I say, I don't even know, I hope, I know that all of your questions have been answered very succinctly and perfectly there. So, barring any more questions that pop in, and if they do, I will go back to them and answer them. That is all we have time for tonight, folks. So thank you all for joining us. Thank you, Sarah, especially, and a huge thank you as well to our sponsors. As always, I'm wearing my little QualSafe t-shirt underneath my hoodie tonight, but do scan the QR code that's on your screen now, especially if you work as a FREC, if you are first aid, if you're any that kind of side of stuff. Do scan the QR code that's on your screen now and check out QualSafe. They've got so many wonderful courses available that you can sign up to, and they're all very, very, very useful. And apart from that, they're just great people. They're just good guys. So just check them out and go over to qualsafe.co.uk.org or scan the QR code on your screen and find out more. And of course, our brand new sponsors, the wonderful T-Car and P-Car, who are all the way across in Oregon, America. And I don't think Laura's with us tonight, which is odd. However, do scan the QR code that's on your screen now. Check them out. They've got some brilliant courses available that you can purchase online. You can do online. It's almost like online learning. It's almost like a virtual university. And they do have it to English standards as well. They've got the English side of stuff. They've got the UK side of stuff, which you can see at the bottom of your screen, which is tcarprograms-uk.org. Really, really good guys. They've got loads of really useful information on their website. So do scan the QR code on your screen and go to them. And finally, thank you to the double trauma care symbol there. I did not know how that happened. We'll fix that one. However, huge thank you to our longest standing sponsors and our very, very good friends over at Galen. We absolutely love them. Bronner, Jay, all the rest of them. Brilliant people. I say it every single week, and I'm going to have to say it again. I cannot speak too much about them because I'm not qualified and they deal with pharmaceuticals, which means I'm not allowed to. However, what they do have available, if you follow the QR code that's on your screen now and click on the for healthcare professionals bit, you'll find out a lot more about them. However, I can't speak about it because I'm not qualified, but what they do is fantastic, and you probably use one of their items in your everyday work environment as it stands. And breathe. That is all we've got time for tonight. So thank you everyone for joining us from all around the world, from all around everywhere. It's so fantastic, again, as always, to see such an international audience with us. It really does make me feel fantastic because it makes me know that I'm doing something right, that we're doing something right to be reaching people. However, the biggest thank you of tonight has to go to Sarah for such a fascinating, thorough, great presentation. Everyone's grateful for it. Everyone absolutely loved it. I can only agree as well. I'm not medically trained and I found it absolutely fascinating. So thank you so much.
It's a
As
pleasure. Thank you for having me.
anytime, absolutely anytime. As always, everyone, wherever you are in the world, take care of yourselves, take care of your loved ones, have a good evening, and good night all.